can't ask for anyone better than Dr. Anthony Aldave to talk to us about cataract surgery in patients with corneal disorders.
Thank you for the invitation to participate. I'm going to speak from a corneal surgeon's perspective regarding cataract surgery and primarily screening your cataract surgery patients for corneal disorders. I have no relevant disclosures. This is part of a longer talk. You're fortunate this is the abridged version. I'm going to talk just about cataract surgery in the patients with epithelial basement membrane dystrophy and Saltzman's nodular degeneration. How common are these conditions? Well, obviously it varies depending on where you practice, but this article from a group in the United States reported in a series of patients, about 120 with cataract surgery, they identified epithelial basement membrane dystrophy in approximately 8% of the patients and Saltzman's nodules in about 2%. So EBMD actually is quite common. Saltzman's less common, but certainly you need to be able to recognize it and manage it if necessary before the cataract surgery, not at the time of. So this is a case of a 72-year-old gentleman who complained of progressive decrease in vision in his right eye. He had cataract surgery previously in the left eye. He wore contact lenses for half a century, and he's told me that if he needed cataract surgery in the right eye, he was interested in a multifocal or a toric lens to optimize his uncorrected distance and near vision. You note on exam his vision is 20/70 with refraction. Exam, I'll show you a slit lamp photograph on the next slide, shows negative staining in the central cornea, a 2+ nuclear sclerotic cataract. In the other eye, he had some peripheral epithelial irregularity that looked like epithelial basement membrane dystrophy and a toric lens well positioned. So this is the right eye. It's hard to see, but there's some lacy gray opacification here centrally that's actually much easier to see here with the fluorescein dye and cobalt blue illumination. So first thing I'd ask you, all of you, cataract surgeons, please always put in fluorescein, use cobalt blue illumination, and look for irregularity like this. You may already do this looking for dryness, etc., for PEK, but you should also be looking for epithelial irregularity. And this patient had what looked like a visually significant cataract. So topography, not surprisingly, showed a fair amount of irregularity with about 3.7 diopters of irregular astigmatism. The left eye, the eye with the toric, had 2.4 diopters of fairly symmetric with the rule astigmatism. So when do you treat epithelial basement membrane dystrophy? Well, when there's visually significant epithelial irregularity. I see on this case, definitely this is visually significant. If you have unreliable keratometry or topography secondary to the irregularity in a patient in whom you're planning cataract surgery. And also, how do you know in this patient if they're complaining of night vision problems, whether the complaint is due to lenticular opacification or the corneal irregularity? You don't know. So you need to treat the cornea first, and then if their problems persist, then proceed with a cataract surgery. And in patients in my practice with this condition, most commonly, they're symptomatic because of recurrent corneal erosions, more so than with epithelial irregularity. My preferred treatment is epithelial debridement and diamond burr polishing. Very easy to perform. You see here with a speculum in, this was because we have a minor procedure room right next to our clinic, so that's why I do the procedure. But many people will do this in their office at the slit lamp. It's quite easy to do. You remove the epithelium initially with a Wexel sponge. Even in patients without a history of recurrent erosions, if they have EBMD, the epithelium is usually fairly disadherent. I then use a 57 blade to remove any islands of adherent epithelium. Then I use this ophthalmic burr. It's about a 2.5 to 3.0 millimeter burr with very fine metallic flecks. In this case, what we're doing is, in essence, polishing Bowman layer. You want to remove the epithelial basement membrane. So debridement alone is not enough. You need to do this step as well. Once you do, then you place a bandaged contact lens. The whole procedure will take maybe 3 minutes. It's very easy to perform. Again, I don't think it should be solely the corneal specialist who does this. I think this is a procedure that's appropriate for general ophthalmologists to perform. So here's the patient following the procedure. You see a much more regular astigmatism here, 1.9 diopters. And the question is now, if the patient's vision improved a bit but still feel like they wants to have cataract surgery, what type of lens can you consider? Is it appropriate to consider a premium IOL in a patient with EBMD? Well, to make that decision, I think you need to go to the literature. We've published several series on treating EBMD with diamond burr polishing. And in this case, we looked at the subset of patients with epithelial irregularity. At this time, it was 42 eyes. We're going to publish our new series, which is now up to about 100 eyes. None have had a recurrence. And this is now with follow-up of up to 20 years. This should tell you that this is not a dystrophy. This is a degeneration. If it were a dystrophy like other epithelial dystrophies, it would have recurred. It also means it is appropriate to put in premium channel lenses in patients if you treat them appropriately. All right. Second condition, Saltzman's. I think you're all familiar with Saltzman's. We see here this isolated inferior nodule, probably from exposure. Here's a patient with prior LASIK surgery with nodules along the edge of the LASIK flap. But here's a patient who I saw last year on their pre-op evaluation for cataract surgery. That cornea looks clear, doesn't it? You may say, well, hard to tell, there's a reflection of the lid up here, so I can't see. Well, if you lift the lid up, this is the reflection of the Q-tip, you don't see anything with this illumination. Again, besides using cobalt blue illumination and fluorescein dye, please also use tangential illumination in all your cataract surgery pre-op evals. Same eye, but now with light coming at an angle, we can see the subepithelial fibrosis. You'd say, well, okay, you see some of that, but what does that matter? Well, that triggers you to do a topography, and look how much flattening you have, 4.3 diopters. You definitely want to recognize this and treat it before cataract surgery than trying to figure out why the patient doesn't see well after cataract surgery. So here we are following a keratectomy, and you notice now a significant irregularity of that cornea. The average K value here, 43.56. Again, prior to the treatment, 41.5. So you have a over 2 diopter steepening following removal of the subepithelial fibrosis. Again, you want to do that before your cataract surgery rather than after, because afterwards they're obviously not going to be happy with the lens power you put in. So what are the indications for treating Saltzman's? Decreased vision secondary to direct obstruction of the visual axis or induced irregular astigmatism, unreliable keratometry or topography secondary to the induced irregular astigmatism, and to differentiate between vision loss between the cataract and the Saltzman's. I would implore you to do topography or tomography in all patients with any Saltzman's nodule, no matter how small it is or where it's located. You never know how much astigmatism it's inducing. The question is it appropriate to put in a toric in a patient who had Saltzman's nodule that you removed? Well, if you look in the literature, this paper looked at several different series of Saltzman's, and they reported follow-up range here of about up to 2 years, and recurrence rates anywhere from 0 to 31%. So what this means is Saltzman's nodules recur not uncommonly. They're due to a number of different conditions, of course, and many of these conditions will cause recurrence of the Saltzman's nodules. So I would say, given the fact that Saltzman's nodules commonly recur, you should not be putting in torics in patients with Saltzman's nodules. All right. Now, what happens if you miss these conditions and you treat them after cataract surgery? Well, this is a paper from the group at Duke, and they noted in patients with EBMD that following treatment, they saw an increase in the average K value of about 2/3 of a diopter, which changed the IOL power, if you're targeting metropia, by almost a little over 3/4 of a diopter. If you're treating Saltzman's nodules and you treat them after the surgery rather than before, you're going to be off by about 1.4 diopters as far as the targeted IOL power. So, in conclusion, topography should always be performed prior to cataract surgery in anybody with EBMD involving the central 5 to 6 millimeters of the cornea. If they only have very peripheral map lines, it's not going to affect their vision. You don't need to do topography. But anything in the central cornea, you should. Any Saltzman's nodule anywhere, though, you should do topography. If you do see visually significant irregularity, you need to do the treatment before cataract surgery, not at the same time. A toric or multifocal IOL, I believe, is appropriate to implant following successful treatment of EBMD, but should not be implanted in patients with a history of Saltzman's. Thank you very much.
Thank you. Can I take a question? You covered these two aspects quite well. Another corneal condition we frequently come across is Fuchs dystrophy. Initially, we used to have a guideline that the cornea thicker than 600 microns, endothelial cell count less than 600, go ahead and combine it with a DSEC or a DMEC. But nowadays, at least in my practice, we always do if the cornea is clear, go ahead with the cataract surgery and address the endothelium if it decompensates. What's your thoughts on this? It's
a good question, and this could be like a discussion for 20 minutes, which we don't have. you know, using just central corneal thickness should be taken into consideration, but obviously there's a lot of difference in the population regarding what is their baseline thickness. So what I say is anytime you have a Fuchs patient, try to get a pachymetry early on when they're young so you know what their baseline is. And I'd say any increase of more than maybe 60 to 80 microns, even if it's only 600 microns at that point, should trigger you to think about doing a combined procedure. The other thing I'd say keep in mind is if you have a Pentacam device, Sanjay Patel has taught us a lot about looking for subclinical edema on Pentacam. There's a few different parameters you can look at, and in my practice, if I see evidence of subclinical edema on the Pentacam imaging, I will typically go ahead with a combined procedure, even if I don't see stromal edema on exam.
Thank you.